Okay. So, should we start? We start. Hello, should we start? Okay. So, Bismillahirrahmanirrahim. So, complications of anesthesia. This is the topic. Now, complication in dentistry, it could be outpatient anesthesia. You might have given anesthesia at dental chair. Sedation techniques, because of sedation techniques, or daycare anesthesia, or it can happen in inpatient anesthesia like complete dental rehabilitation, complications of oral surgery, surgical procedures, or major maxillofacial surgery. There could be this anesthesia problem that can happen. Now, who are the patients who have high risk for complication during anesthesia? Patients of extremes of age, like infants, adult patients, children's. So there is possibility of high risk, complication that can happen due because of anesthesia. Patients who have difficult airway, congenital, as well as chronic acquired disease, emergency situation. When you are doing any procedure in emergency situation, there is high possibility of complication that can happen. Now, the second factor could be, clinician factors like knowledge, technical skills, and crisis management of a particular person who is giving anesthesia. Now, inadequate preparation of patient or equipment is more likely to cause damage. So, because of clinicians' knowledge, technical skills, and how he or she is going to manage the crisis situation, it is also a dependent risk factor how a person is going to manage that complication that has happened. Now, equipment failure can happen. Now, physiological and pharmacological effects of drugs could be the risk factor, like how the drug is going to affect what is the positioning of the patient, is the stress response due to surgery, stress response due to anesthesia. So all these things will determine whether a particular patient will have the anesthesia complication or not. Now, very common that like complications, it could be 1 in 10, common 1 in 100, uncommon. These are the statistics that you are going to say, okay, this is the common or very common or uncommon or rare complication. Now, very common complication and side effect of anesthesia is like if somebody has gone, being through anesthesia, he may feel sick or vomiting. There may be post-operative nausea, vomiting, sore throat because of these instruments that we have put, may feel dizzy or feeling pain because of the regional anesthesia or general anesthesia. Patient might be having shivering, headache, or itching. These are very common complications. Like, yeah, I mean, if somebody has gone into anesthesia, these are the things that we come to know in the post-operative period. Okay, the patient is feeling nausea, vomiting, patient's having sore throat, patient's having headache, or in other way, these are the problems that, these are some way avoidable, but yes, to some extent, these are very common presentation in the post-operative period. Now, very common are like patient having aches or pains in the back because of regional anesthesia. There could be bruising or soreness or because of general anesthesia. Patient have memory loss or confusion, and but that is the transient. It's not a permanent thing that can happen. So these are, when we get the patient out of the anesthesia in the post-operative period, maybe for a couple of hours they will be confused or not oriented properly, or there could be memory loss also. It can happen as a part of anesthesia problem. Now, chest infections could happen as a result of general anesthesia, bladder problems or muscle pains, because of general anesthesia. Now, uncommon problems, why I'm saying uncommon, because if these problems happen in the post-operative period, then we have to be very careful that there is this very uncommon complication that has happened, like breathing difficulty. Like if I have done the general anesthesia or regional anesthesia to the patient, if the patient in the post-operative is complaining of breathing difficulty, patient is not breathing well, patient is having hypoxia, patient is having saturation on the lower side, it's a very uncommon thing that can happen. So we have to be very quick, and we have to do the prompt response during that problem. Now, damage to teeth, lips, or tongue, this is also very important and uncommon complication that can happen. It's a medical legal. Somebody has gone into anesthesia, and in the post-operative, he or she is feeling problem in the tooth, or there is this loss, or there is damage or injury to the teeth. So this is a medical legal thing. We have to be very careful. There could be worsening of existing medical condition. For example, if a patient is having some COPD, if your patient is having some asthmatic problem, patient is having hypertensive, there could be a worsening of situation that can happen in the post-operative period. Now, awareness is another thing that can happen. Awareness is one of the most, you can say, uh, it can lead to psychos problem also if a patient is aware during the anesthesia. Now, what is awareness? That although the patient was under sedation, patient was having muscle relaxation, but still the patient was aware about the situation, what is happening around. Imagine how the situation of patient will be if the patient is hearing or listening everything that is going during the surgery. So it's a very not a good thing that if a patient is aware about the situation. Now, mainly the reason is, we haven't given that much adequate analgesia, we have not given that adequate amount of sedation, or the level of anesthesia was not that deep. Patient was able to hear or listen, or patient was having all listening all the conversation that was happening. So this is what is known as the awareness during anesthesia. We try to make sure that we are getting this, we are not facing this problem during the anesthesia. Now, very rare complications like damage to eyes. If you have done the patient, you have done anesthesia. Now the patient is coming in the post-operative period. There is damage in the eye. This is a very rare complication. That means there is something that has happened during the operation. Serious allergy to drugs like general anesthesia or regional anesthesia. Most of the drugs that we use during the anesthesia, least likely that they can lead to any allergic response. But yes, there are cases that there is possibility that it can lead to serious allergic reactions. Nerve damage, very rare complication. Death as a part of anesthesia, it's a very rare. Let me tell you, nowadays anesthesia is very safe, secure, and it's a balanced thing. Okay, so it is not like a previously what people used to go for anesthesia. It's nowadays, I can assure you that it's one of the safest thing that is present, and that is the reason we are doing all these surgeries. Advanced surgeries are possible because of the advancement of anesthesia. Okay. Now, as far as respiratory complications, there could be difficult airway or the failure to intubate, like in case of, maxillofacial trauma. You might not be able to open the mouth. There could be problem in intubation, laryngoscopy. So you can face a difficult airway situation. Now, respiratory complications, the reason could be that tongue is falling to the posterior pharyngeal wall, or there could be some blood or debris or laryngospasm in the post-operative period that has led to hypoxia. Or patient will have in the post-operative period, maybe the patient is having over sedation or narcotics. They have given more narcotics, like what we give for analgesia, like morphine, like fentanyl. So maybe patient have respiratory depression because of the overdosage of these drugs. Now, management, as I said, you have to do the basic airway management. You have to oxygenate the patient. Maybe if the patient is not getting better, you have to put the patient on ventilator. Now, hypoxemia, what is hypoxemia? It's lower arterial PA, partial pressure of CO2, okay, O2. So partial pressure of O2 oxygen, when it is low, it is known as hypoxemia. Now, what could be the reason? It could be equipment failure, hypoventilation. When you are putting the tube inside, you are not able to, ventilate properly, or the patient factors could be there. Now, when a patient is in hypoxia or hypoxemia, what are the signs? There is the compensatory response like tachycardia, sweating, hypertension, arrhythmia, bradycardia. It's very severe, especially in children's. Bradycardia, hypotension, and arrest can happen later if a patient you are not able to reverse that situation. So, if a patient is having hypoxemia and it's continuous and it's severe, it can lead to bradycardia, leading to hypotension, and leading to cardiac arrest. Now, prevention, these are all preventable. 100%, you have to give 100% oxygen. You have to make sure that you are not mixing the gases with other, so that it can be, hypoxemia can be avoided. You have to check the breathing system. You have to make sure that there is no VQ mismatch, and arterial blood gas analysis and X-ray has to be done in such situations. Now, hypercarbia, it is simply CO2 on the higher side. Okay, so what could be the reason? The most important, inadequate removal of CO2, or the patient is having, you have put the patient under general anesthesia. Now you are doing hypoventilation, CO2 is not coming out. So it could be other reason, could be excessive production, or the patient might have fever, sepsis, hyperthyroidism. So there could be possibility that their CO2 production is very high. So in case of laparoscopic surgery or anesthetic machine problem, you can have CO2 on the higher side. Clinical features same. There is a sympathetic response, like patient will have tachycardia, sweating, arrhythmia, tachypnea, high potassium, and the treatment options we have to make sure that we are treating the cause, we are supporting the ventilator. The ventilatory support is there. You make sure that the circulatory support in case hypotension is there. Now, hypocapnia or hypocarbia, you can say the CO2 levels are less than 35 or 4 kps. Hyperventilation could be result. It can result in this condition. Now, aspiration is one of the dreadful complications that can happen during the anesthesia in the post-operative period, or at the time when you are putting the tube inside the patient's trachea. Now, there are other reasons, there are multiple reasons. The most important is that patient is not fasting. So there is a fasting protocol we have to follow, patient has to follow before going for anesthesia. If the patient has not followed the fasting protocol, there is high possibility of aspiration that can happen. Now, aspiration, simply the stomach contents are going inside the lungs, and there is a chemical reaction, or because of this big vomitus, it can lead to mechanical obstruction. So aspiration can happen. So we have to follow the fasting protocol. There are other reasons, like if a patient is having pregnancy, patient is hiatus hernia, patient is gastroesophageal reflux. These are the patients where there is high risk for aspiration. Now, in order to prevent this, if we feel that the patient is having high risk for aspiration, we can have the different management protocol, like we can do rapid sequence intubation, awake intubation, or you can have other options to tackle this situation. Now, as I said, rapid sequence intubation is simply putting the tube quickly inside the trachea without wasting time or without ventilating. You just have to put the tube inside, so that you cannot, put the air inside the stomach. Otherwise, there is high possibility. Again, it will lead to aspiration risk. Now, hiccups in the post-operative period, it could be as a result of vagal stimulation. You can give anticholinergic or metoclopramide, or you can sedate patient so that this problem can be avoided. Now, cardiovascular complications, like during the tooth extraction, there could be high preoperative corticolamine, light anesthesia or airway obstruction and hypoxia, halothen and local anesthesia with vasopressor. There could be possibility of arrhythmia that can happen at this time. Now, significance, it could be controversial. there could be a significant with unexpected cardiac disease like viral myocarditis. Now, bradycardia as a result of tooth extraction that can happen, because of the vasovagal, or it could be as a result of halothane that we have used, it can happen. Hypertension in bad control hypertensive patient can have in the post-operative period. Patient can have hypertensive response. Okay, so because of inadequate analgesia or the previously known case of hypertension, patient or inadequate, full bladder. These could be the problem. Patient can have hypertensive, or patient is not on regular medication of hypertensive medication. So problem hypertensive patient, we can have a patient with hypertension in the post-operative period. Now, hypotension, it could be as a result of myocardial infarction, or it could be MI or renal failure, or hypertensive shock situation can lead to this hypotensive state. Now, as a part of basic airway management, I already discussed this thing in my previous lecture also. We can do head tilt, chin lift. If you have a patient in the post-operative period, now the patient is not breathing properly, you can do head tilt, chin lift, jaw thrust, and you can have an advanced airway management by putting oropharyngeal, nasopharyngeal airways. These are the other options, or you can do the endotracheal tube intubation. Now, if you have been asked in your exam, endotracheal tube intubation is the most preferred method of advanced airway management. So you might be asked, which of the following is the most preferred method? You can say endotracheal tube intubation. Now, the only indication for surgical airway is the inability. If I'm not able to secure the airway, then we can go for surgical airway. Now, the other minor complication like hypothermia, these are very important but rare complications like awareness, as I said, nerve injury, thermal and electrical equipment problem that can happen. Allergic reaction, very rare, more commonly with, you can have vasovagal toxic reactions or epinephrine. You can give what could be the etiology. It is because of the excess histamine release, IgE mediated reaction. So allergic reactions, as I said, these are very rare complications that can happen as a part of anesthesia. But most of the drugs that we are using, they cannot lead to the allergic reaction. So the other things, what is the definitive management of air? We have this epinephrine, 100% oxygen. We have to manage the ABC, like airway, breathing, and circulation. Most of the time there is this distributive type of shock that we discussed in our previous class. What is the definitive management? You have to make sure you are reversing this vasodilatory effect by giving the epinephrine. So you have to give IV fluid, 100% oxygen. Maybe you might have to intubate the patient if the patient's allergic response is too much that it has resulted into the angioedema. Now, seizures can happen during this surgery or after surgery if a patient is known case of seizure disorder. So you have to make sure that you are doing ABC in that situation. You are giving the seizure suppressing drugs, or like intravenous diazepam. You are giving supportive treatment, and you are taking care of the other things. Now, miscellaneous like nasal trauma, epistaxis, pulmonary aspiration, diffusion hypoxia, continued bleeding, post-operative sore throat, post-operative nausea, vomiting, post-operative pain and swelling. These are all miscellaneous complications that can happen. Now, there is one thing that can happen with when we are giving local anesthetic agent, like when you are doing this dental extraction, you use lignocaine as a part of local anesthesia. Now, there could be allergic reaction that can happen. It can lead to toxicity, especially neurotoxicity. There could be vasoconstriction. There could be vasovagal response that can happen at the time when you are injecting this local anesthetic agent. Now, what you can do in such situations, you can make sure that you are flat. You make the patient flat. You do the head down, leg elevation, and give the 100% oxygen. And if the patient is not responding, patient is having severe brady, you can give atropine or vasopressors as a part of maintaining the circulation. Now, there is a cascade of systemic toxicity with local anesthetic agents. Now, if you have been asked if I'm giving local anesthetic agent, there is a toxicity that can happen, and it is a dose dependent toxicity. It's not only that at a particular, it can happen with a smaller doses also. But yes, there is possibility if you are giving more doses, if you are exceeding the dose, safer dose of local anesthetic agent, you can have a patient with systemic toxicity. Now, what is the first sign that the patient will tell you that, okay, the doctor, I have this problem? So there will be circumoral numbness around the tongue and the lips. You can have, you can hear from the patient that the doctor, I am feeling some, tingling sensation around my mouth. So this is the first sign of local anesthesia toxicity. So it can be asked in your exam also, which of the following is the first sign of local anesthesia toxicity? It is the circumoral numbness. Patient can have light headiness. Patient have visual disturbances. Patient can have tinnitus, muscle twitching, tonic convulsions can happen as a part of local anesthesia complication, or respiratory depression and cardiac arrest, and if death if not treated promptly. So management, what we can do prevention. That is the best thing. You have to make sure that whenever you are putting this local anesthetic agent, just do the aspiration, then put small doses of local anesthetic agent, and please do not exceed the maximum amount of this toxicity and dose of for the toxicity. Now, if you have the patient with the suspected local anesthesia toxicity, you have to follow ABC approach. You have to give the supportive oxygenation and ventilation. You have to support the circulation. You have to control the seizures. Then what you can do? So these are the things that you can do in as a part of treatment for local anesthesia toxicity. So this is all, and the questions from this topic. This is a very big topic, and for you to, for your point of view, if the questions are asked in this topic, it's simply what most, just try to focus on local anesthesia toxicity. Okay, so what is the first sign of local anesthesia toxicity? How you can prevent the local anesthesia toxicity? Okay, and the other thing will be aspiration. What are the risk factors for aspiration? How you define aspiration? How you can control aspiration? Okay, so these are, and what is the fasting protocol? Now let me tell you the fasting protocol that I haven't mentioned here. If we try to keep patients, always try to, whenever we have to do the big procedure like general anesthesia, we try to keep 8 hour fasting for solids and 6 hour for semi-solid, like milk also is a semi-solid. Okay, and 2 to 3 hours for liquids, clear liquids like water. So patient can have 2 to 3 hours before any procedure, major procedure, 2 to 3 hours before he or she can have water or clear liquid like tea without milk. Okay, or if a patient is like, for example, if the patient is having some problem like gastroesophageal reflux disease, the fasting protocol is very high in that situation. So these are the questions mostly that can be asked in this topic. Now, for your point of view, just bear 5 to 3 minutes with me. I just want to show you one thing. Now, I was discussing all these things. Maybe I was not, I couldn't demonstrate what I'm telling you. You can you can go to this YouTube. Okay, so what I have here, Dr. John 5, Dr. Shan, and you can say at the rate Dr. John 5. So Dr. John 5, you can at the rate Dr. John 5. You can see my channel. I have explained each and everything regarding all these topics what I was discussing with you, how you can do head tilt, chin lift. There are multiple videos. Okay, so there are multiple videos where you can have a little bit inside what I was discussing with you. Like for your point of view, what I can say, like nasopharyngeal airway, how we can use it, okay? And other are how to do basic airway maneuvers, head tilt, chin lift, how to do bag mask ventilation, okay? And you can check how what is the first fasting guidelines for a patient, how to do the rapid sequence intubation. There are shorts for simply learning purpose. You can learn the basic airway, like how to do this, open the mouth, how to put the laryngoscope, how to use the laryngeal mask airway. Okay, so how to do the jaw thrust that I was discussing, how to do the head tilt, chin lift, how to do mask ventilation. So you can go through this, and inshallah it will be useful. Thanks for having patience, and inshallah, just give me your attendance. You can send me attendance like previously you sent that on my WhatsApp. So if you have any question or any doubt, you can ask me right now. Is it clear? Okay, thank you. Thank you very much. Thank you. My daughter is also calling me now. Okay, Shukran. Thank you very much. Thank you.